Dear colleagues, it is an absolute joy to host you here in Ankara. My name is Erdem and I will talk about the subscapularis tears in this session. It's a privilege to be in front of you today. So subscapularis muscle is the largest and the strongest muscle of the rotator cuff. It spans on the entirety of the anterior scapula, and its function is dependent on the position of the humerus. As the deltoid abducts the shoulder, the rotational vector of the subscapularis tendon and muscle becomes more like a compression force than an abduction force, and it aids the deltoid stability during the abduction, and it's therefore crucial for shoulder range of motion. It also creates a double-sided compression force with the contracting infraspinatus and teres minor muscles. It aids the anterior stability of the glenohumeral joint as well. It's one of the dynamic stabilizers of the joint. Isolated tears are quite rare in our clinic. We don't usually come across isolated tears of the subscapularis. This is probably because the patients with isolated tears probably don't have as loud symptoms as other patients, and they rarely get admitted to our clinic, and they rarely get diagnosed without surgery. However, we encounter subscapularis tears quite a lot in our practice. This is because it accompanies many of the other shoulder pathologies. Mostly long head of the biceps tendon pathologies, slap lesions, and superior cuff lesions are the lesions that accompany subscapularis tears the most. You can expect to encounter subscapularis tears in up to 50% of cases you perform for rotator cuff pathologies. Why is that? Why are they accompanying each other that much? It is due to subscapularis having a unique anatomy. It has connections, ligamentous connections to the anterior sling of the biceps tendon, and superior glenohumeral ligament and coracohumeral ligament are being supported by subscapularis in their insertion. It also, via coracohumeral ligament, joins to and forms up the rotator cable anteriorly. Therefore, you can expect long head of the biceps tendon instabilities in these tears, and you should expect supraspinatus also being affected due to rotator cable being disrupted in these tears. This figure also shows the close relation of coracohumeral ligament and superior glenohumeral ligament to the subscapularis tendon. The light blue colored structure shows these ligaments. Anteriorly, these connect and form up the anterior sling of the biceps tendon. I'm repeating myself because this is the most important aspect of subscapularis tendon tears. And once this structure is disrupted, you can see a dislocated biceps tendon and the rotator cable losing its support and causing shoulder problems. A team led by Ulunay Kanatlı from Gazi published the accompanying ratios of these lesions. They found that almost all of the subscapularis tears had slap lesions, and close to all of, more than three-fourths of these tears were accompanied by long head of the biceps tendon pathology and superior cuff pathologies. Etiology is not that clear actually. It is thought to be similar to other cuff pathologies, which is intrinsic degeneration causing most of the problems. Mechanical etiology is now being debated. Previously, it was thought that coracohumeral distance and coracoid morphology contributed to these tears, but now we know that with increasing evidence that coracoid morphology does not actually correlate with subscapularis tears all that much. So subcoracoid impingement and morphology is now being debated as a reason for the etiology. Trauma is an important etiology. It forms up the isolated tears mostly. It is seen in elderly patients with anterior shoulder dislocations. Therefore, it should be checked with specific trauma. If patient has suffered specific trauma, it should be checked. Physical examination gives us a quite specific idea about the diagnosis. However, it's not that sensitive. The latest studies show that a combination of belly press test and bear hug test can produce a diagnostic value close to MRI scans, but still you should not 100% rely on these methods. If you encounter a subscapularis tears, that's fine because you can catch it, but you can miss many of the subscap tears with just physical examination only. Actually, imaging is not much different in terms of diagnosis. I don't know your experience, but in my experience and many other colleagues' experience in Turkey, it's really hard to get the radiologists to report these tears. They usually report the superior cuff pathologies, but subscapularis is left mostly undiagnosed. So we have to always keep a keen eye on all the planes of the MRI images and look for clues that may lead us to the diagnosis. These are the 4 specific images that I brought to present to you. First is the subcoracoid impingement. As I said, this is now being debated, but it can be a cause of subscap tears. If there's a coracoid osteophyte or something that reduces the volume, it can lead to it can give you an idea about subscap tear. You can, in axial oblique plane images, you can see that the contours of the subscap tendon may be disturbed and may become irregular, and the long head of the biceps may be dislocated from its groove, the bicipital groove. This shows you that there is a subscap tear. And on sagittal oblique plane views, subscapularis atrophy might be present, which will give you an idea about the diagnosis. And this is a very new study, also published by our team led by Professor Kanatlı. It shows that in the same sagittal oblique views, that effusion in the superior recess of the subcoracoid space can also be a good diagnostic parameter. Also by our team, there is a study published in 2016 or 19, I don't really remember, but we examined the greater tuberosity cysts being, it's related to superior cuff tears. We examined if the lesser tubercle cysts were associated with subscapularis tears, and we found a correlation. It can be an surrogate for diagnosis. But as I said, these diagnostic parameters before the operation typically leave much left to be enlightened. So during arthroscopy for all your shoulder pathologies, during diagnosis, the first look, you should look for the subscap tears specifically. You may not be aware of it before the operation, but you have to look for it in the operation. Looking at several specific images, trying to look for them will increase your diagnostic capacity. First one of these parameters is the coma sign. This is defined by Stephen Burkhardt in 2003. This is actually the superior glenohumeral ligament and coracohumeral ligament being pulled medially by the torn subscapularis tendon. By being pulled medially, they form a vertical curtain-like shape which guides you to the insertion of the subscapularis. Let me show you better on a video. As you see, this is the vertical curtain-like structure on the mid-glenoid portion. When it's reduced by a blunt trocar, you can see that the subscapularis moves to its anatomical position on the lesser tuberosity. If you see this vertical curtain, you should expect a subscap tear. This is the superior glenohumeral ligament and coracohumeral ligament, and they can be inserted back into their original position, which will give the shoulder the anatomy that you are more accustomed to. Airbag sign is a sign for interstitial tears. They make up for 10% of the subscapularis tears, and they're not that common, but if you see a airbag sign, which is defined as the scar tissue within the tendon, you should expect an interstitial tendon tear. Sentinel sign is another popularized by Laurent Lafosse. It's a popular sign that will make the surgeon think about subscapularis tear. It is the anterior portion of the biceps tendon being degenerated and frayed. This is due to the chronic instability on the biceps tendon. As I said, the subscapularis supports the anterior sling of the biceps, so it's not surprising to see anterior fraying and degeneration in these tears. Similar to the sentinel sign, Professor Kanatlı and his team also published another sign, which is called the forelock sign. Forelock sign is very similar to the sentinel sign, but it is actually not the fraying of the biceps tendon, but it is fraying of the ligamentous structures that I mentioned. They fall on the humeral head like frayed tissue, like forelock on the hair. And this is the advantage of this, is that you can observe this even in the absence of the biceps tendon. If the biceps tendon is torn, you can still see the forelock sign. Posterior lever push defined by Burkhardt will also help you identifying and showing you the extent of the tear. By pushing the glenohumeral head, glenohumeral joint, posteriorly, subluxating it, you can see anteriorly that the subscapularis tendon will move anteriorly, and this will help you identify the extent of the tear. If you have trouble identifying the tear, you can use this method, but it's recommended that you use this method with a 70-degree scope to better see where the extent of the tear is. Once you identify the tear, you have to classify it to choose the appropriate treatment. Lafosse classification is the most commonly used classification. The first 3 types of tears make up for more than 90% of the tears. These are, first one is rather, less encountered, but type 2 and type 3 are full thickness tears of the subscapularis, and it's the upper 2/3 or 1/3 of the tendon being disrupted. This is, as I said, the most common type of tears. They can be managed with simple repair techniques. We typically use a single row technique with these tears, and simple sutures with a single suture anchor is typically enough. But if you have a type 4 tear, which is full thickness, it goes all through the entirety of the subscapularis muscle, then it requires a more substantial release and more extensive approach. It will be really difficult to perform if you are a surgeon without extensive experience. Releasing the subscapularis from the medial, going past the coracoid process, going past medially from the conjoint tendon, you will see the plexus, and you will see nerve endings that penetrate the subscapularis muscle. So if you have type 4 tears, you may also consider open surgery as a safer and maybe any faster method if you are, you don't have that much experience. Type 5 tears is heavily fatty infiltration is occurred, and you have to consider more advanced methods. Here you can see the arthroscopic view of Lafosse type 2 tears. This is a full thickness tear on the upper third. It can be repaired with a simple repair technique, but in a more advanced type of tear, you would need more advanced repair. As I said, these tears are more than 85% of the time are accompanied by supraspinatus tears. So in their coexistence, you have to keep in mind that if you repair the subscapularis first, you will have a significant advantage. As I said, reducing the subscapularis on its original position will reduce the rotator cable as well, and it will also pull the retract the supraspinatus tendon to a more manageable position. If you saw a scary and a very extensive tear of the supraspinatus, you can expect to see that it will turn into a more concentric and easier to manage tear once you repair the subscapularis tendon. Here is the cadaver dissection of what I'm talking about. Anteriorly, you can see the subscap, and these ligamentous structure called the rotator cable. Once you pull the subscap, supraspinatus becomes also pulled and becomes easier to manage. We use standard portals. Initially, we start with the posterior portal to view. We typically use 30-degree scopes. We don't usually need the 70-degree scope. And anterior, we use 2 portals. You can use 1 portal and a sutureless anchor if you like, but Our experience is with two anterior portals and suture anchors. The first anterior portal is a standard portal, and the second one we open to prepare the bony bed and to pass the sutures through the tendon. The second anterolateral portal, we recommend opening it as parallel as possible to the subscapularis tendon mass. Here you can see a type 3 tear. First anterior anchor, we try to, this is a little fast, sorry. With a spinal needle, we determine the anterior anchor's position. It's really hard to, yes. Here with a spinal needle, we try to aim for the just anterior to the long head of the biceps, just anterior to the biceps groove, and we try to achieve a 90-degree angle with our anchor insertion. We prepare a bony bed by debridement. Anchor is placed. You can rotate the shoulder to achieve a 90-degree insertion angle. Then the first suture is passed with a suture lasso, and the first limb of the suture is passed. A sliding knot is placed, and then the second suture is passed through the tendon, similar to the first one, and a single row repair is completed. Once you do this, if it's an extensive tear, you will see that the shoulder anatomy will become more like the anatomy that you are more accustomed to. So always start with the subscap first. After repair, you will see the subscap tendon. Coracoplasty, as I said, is a now debated topic. Routine coracoplasty is now not being recommended as the mechanical etiology is being questioned. But if there is a coracoid osteophyte, you can reach the coracoid by excising the interval and reaching it, and you can remove about 1 centimeter of bone with a motorized burr, and you can increase the coracohumeral distance. Our team also published another study on this. It is a very valuable study because it only includes isolated subscapularis tears, and all the patients here have similar coracohumeral distances. One group received coracoplasty routinely and the others didn't, and the outcome was similar in 2 years, so we are straying away from coracoplasty quite a lot. To sum up, we can expect similar outcome in subscapularis repairs to other supraspinatus or infraspinatus repairs. It's a largely successful operation. The thing to keep in mind is that we should be aware of this pathology. We should have a keen eye to identify them. We should follow the hints and then perform the diagnosis and do a proper repair, which is not that complicated for the most part. If we neglect the subscapularis tears in the initial operation, we can expect 40% of revisions being due to subscapularis tendon being neglected. And we should also keep in mind that if we don't repair the tendon in the index operation, then even if we repair it in the second operation, our success will drop significantly. As I said, subscapularis tendon tears is the subject of shoulder arthroscopy in the last 15 to 20 years. Before that, it was largely unknown. With the advancement of arthroscopic techniques, we were better able to realize its actual function and actual anatomy and what repairing it brings to us. So there is still much to explore. There are subscapularis tears, papers about subscap tears being published every day. And having said that, I would like to invite you all to publish your valuable data to our journal, Joint Diseases and Related Surgery. Editorial board of this journal consists mostly of the faculty of this course, including Professor Kanatlı. We are indexed in all the major indexes, and we would like to welcome you there as we welcomed you here in Ankara. Thank you so much for your attention.